Okay, good afternoon, everyone, and welcome to teaching today. Today, I wanted to talk about status epilepticus in children. We've given some other teaching on epilepsy in children, which has included a bit about status epilepticus, but I thought it was worth talking about status epilepticus or refractory seizures today because it is very common and it actually is very complex. It's complex, especially when diagnostic imaging is limited, and it's complex when there's a multitude of different pathologies that could cause status epilepticus in children, and sorting out which children have something relatively benign from children that have serious central nervous system pathology I think is very challenging, and it's a clinical challenge that we face regularly. I think several times a week in most hospitals, a child with refractory or recurrent seizures would present, and so we need to have some knowledge and some skills in how to manage such patients. So it's a very clinical talk today. I'm going to be talking about some new things in status epilepticus, some new medications that are a bit safer than the older medications. And I'm going to be talking about a systematic approach to managing children who've got refractory or recurrent seizures. Okay. So let's start with the case. This was a 8-year-old boy who had fever and a seizure. And already you know a little bit of information that may help you in your management of this child. He'd been previously well. He was a well-grown child, well nourished and otherwise well. He'd only been unwell for 2 days, and he'd had respiratory symptoms and a temperature of 38.6. He had two seizures in the children's emergency department after having some unusual movements at home. His mother brought him to the children's emergency department. In the children's emergency department, he received some paraldehyde intramuscularly, and then because of his fever, he was put on artemether and he was given some ceftriaxone, and he had a blood glucose that was 5, and he was still in a very sleepy state. He was in terms of his AVPU score, had a P for consciousness, which means he only responded to painful stimuli. He didn't respond to verbal stimuli or calling his name, and he certainly wasn't alert. And while he was in the ward, so he was transferred to the ward after receiving those medications, and then while he was in the ward, he had two further quite prolonged seizures. And the question is then, what do you do next? Because this child's got refractory or recurrent seizures, or some would call it status epilepticus, a child who has a series of seizures but does not return to the normal neurological baseline. And I think that's important to understand a definition of status epilepticus. It's not necessarily a child who has continuous seizures, is seizing all the time, but it's a child who has seizures and then uh, sometimes a break, but they don't return to the normal baseline, and then they have further seizures, and it's happens on more than 2 or 3 occasions. So fever and refractory or recurrent seizures or status epilepticus. And it's always useful to go back to the basics when you're thinking about any seriously ill child and understand the stages of management and the way we should manage these patients. And it applies as much for status epilepticus as it does for most other conditions. So all these patients need to have a systematic approach at triage. They need to have emergency signs identified if they have any, and receive emergency treatment, which invariably, as with this boy, will include anticonvulsants, but also airway, breathing, sometimes circulatory support. You should take a history and do a full examination, because it's through the history and the examination that you're able to differentiate between those causes of status epilepticus that are benign from those where there's serious central nervous system pathology. And sometimes that examination and that history needs to happen several times so you can elicit the clinical signs as the child evolves, as they improve or fail to improve. Then some laboratory investigations if required. This child had already had a blood glucose measured, but there are other investigations that might be done in a child with status epilepticus, including imaging of the child's brain and electrolytes, and some other investigations we'll cover. And then coming up with a main diagnosis and then other diagnoses or a differential diagnosis, providing definitive treatment for that diagnosis, providing supportive care and monitoring, very essential for children with status epilepticus. And then when they recover, discharge planning and follow-up, and deciding whether or not the child needs any ongoing therapy with anticonvulsants or any other ongoing therapy. All these children, of course, need follow-up because many of them may have neurological deficits or not. They need to be followed up for all of those things. So we'll talk about all of those stages, and we'll talk about the status epilepticus, its management and prognosis. At triage, we've talked about this before, but you take a brief history, as we said, 2-day history of fever and then having seizures, fever and some respiratory symptoms, and then having seizures. You take the child's temperature, it was 38.6, weigh the child so you know the right. You can calculate drug doses appropriately, and you can assess whether or not the child's well-nourished or undernourished or malnourished. Then we've talked before about how to do a rapid triage assessment that pays attention to the child's airway, to their breathing, to their circulation, and their level of consciousness. So by now you should be very familiar with those things, and you should be practiced in identifying those clinical signs, the airway signs of stridor and obstructed breathing, snoring, gurgling, respiratory noises, looking for cyanosis or signs of respiratory distress, and we've talked about those. And then in terms of assessing the circulation, remember, to start with, all you need to do is feel the hands and feel the feet and feel if they're cold or warm, and feel the capillary return and feel the radial pulses. Very important that you get that. If the hands are cold, then feel your way up the child's arm and up the child's leg to see if all the limbs are cold. And then assess the level of consciousness. Remember using the AVPU score. And for this child, he scored a P, which means he's got the lowest level of consciousness apart from being totally unresponsive. As I said, the causes of prolonged or recurrent seizures are complex, and many of them are relatively benign. So the child who has a febrile convulsion may have a couple or a cluster of febrile convulsions, but still will recover neurologically normally without any injury to their brain and without any sequelae. And then you still need to make a diagnosis of the underlying problem, but if you can diagnose recurrent or prolonged seizures as being febrile convulsions, then you don't necessarily need to do any further imaging if the child is following the expected trajectory of recovery from their convulsions. There are many children, of course, who have epilepsy and underlying epilepsy syndrome that have prolonged or recurrent seizures and may go into status epilepticus, and that's usually relatively benign too. You can usually get their seizures under control. The seizures are often triggered by an intercurrent infection, a relatively minor infection that leads to an increase in their seizures. But then there's a whole series of conditions that can cause prolonged recurrent atypical seizures with or without fever, where there can be serious brain pathology, including meningitis and cerebral malaria. The cerebral hemorrhage is not that uncommon in children. Viral encephalitis, which is probably as common or more common than bacterial meningitis, which we always think about, but viral encephalitis is actually quite common. And then central nervous system tuberculosis, either CNS TB manifesting as tuberculous meningitis or as a tuberculoma, relatively common as well. Brain tumors occur in children. They're much rarer, but of course they may present with a prolonged seizures with seizures, and you need to know how to identify those. There are some children that have cerebral malformations that can lead to, either in isolation, they may have normal development, but they've got a cerebral malformation, a small lesion that is a trigger for seizures. We've seen quite a bit of tetanus recently, and it's important to be able to distinguish in a way tetanus from recurrent cortical seizures. Remember, seizures are a abnormality of cortical electrical activity, whereas tetanus is an abnormality of the peripheral nervous system, toxin in the peripheral nervous system. And then there's a range of metabolic disorders, inborn errors of metabolism, where usually there's some clues to the fact that the child might have one of those, and they usually present in the neonatal period or in infancy with seizures. So it's good to have a list in your mind as to what might cause prolonged seizures. Now, they're all causes of primary brain injury. When we think about any child who has an encephalopathy, we need to think about it in two ways. One, what's the primary brain injury? And the other one is there any secondary brain injury? And unfortunately, many children who have prolonged convulsions also can get secondary brain injury. That applies to any child who's got a brain injury of any sort, including and particularly traumatic brain injury. But we need to know what the causes of secondary brain injury are so that we can try to prevent them. And much of the management of such patients with prolonged seizures or with any sort of encephalopathy is the prevention of secondary brain injury. And these are the causes of secondary brain injury. They include hypoxemia, hypoglycemia, hypotension. So anything that reduces the oxygen carrying capacity to the brain, oxygen delivery to the brain, is likely to cause secondary brain injury. Children with hypotension, if there is cerebral edema, either because of persistent seizures or because of the underlying brain pathology, or sometimes iatrogenically because of fluid overload, these children will do worse. And then seizures themselves may cause a form of secondary brain injury if there's not adequate substrate for metabolism in the brain. So if the child's not provided with sufficient glucose or oxygen or hemoglobin, or they have a very high fever, and that can lead to an injury to the brain in children who have very prolonged status epilepticus. I won't go through this table in all detail, but you'll be familiar with, in the WHO Hospital Care for Children book, there are tables of different clinical syndromes, such as a child with severe respiratory distress or a child who's got chronic cough. And there are tables of the diagnosis, the likely diagnoses, which are all the ones I listed before. And then there are some clues. And these clues are clinical signs that you can elicit on history, or you can identify on clinical examination, or using relatively simple tests. You can differentiate the different types of central nervous system pathology, in this case, in children who've got status epilepticus. And part of the job, part of the task in a child with status epilepticus is, as I say, trying to distinguish between what's relatively benign, the child with febrile convulsions that are usually not focal, and the child makes an expected resolution of those neurological signs and is not left with any residual signs such as a hemiparesis or a cranial nerve palsy. It's a diagnosis of exclusion, but it's also, you have to wait and see what the expected recovery is. And most children who've got atypical or prolonged febrile convulsions or recurrent febrile convulsions, they will be treated with antibiotic for the possibility of meningitis, and of course an anti-malarial if they come from a malarious area, and other things will be considered. But in the end, you might conclude that the child's making the expected neurological recovery of a child who's had a prolonged febrile convulsion, and you can diagnose it as being that. I won't go through all the other signs, but you will know them yourself. The signs that are more specific to meningitis, for example, or more specific to cerebral malaria. With cerebral hemorrhage, usually there's an abrupt onset. A child may have had some grumbling headaches, but usually quite an abrupt onset of seizures or an abrupt onset in an older child of a severe headache followed by seizures. They usually don't have a fever. And of course, so for some sorts of CNS pathology, you will need to do some brain imaging um, to be sure it's a hemorrhage compared with something else, such as a brain tumor or a tuberculoma or meningitis. We know the clinical features of viral encephalitis. Again, non-specific, it's hard to distinguish them from bacterial meningitis and CNS tuberculosis. Sometimes you'll be able to identify that on the history of other features that are consistent with TB. Brain tumors usually, not always, but often there's a history of headache. Sometimes there's a neurological deficit. And if you're going to do a CT to rule out cerebral hemorrhage and try to diagnose a brain tumor, then you need to use contrast for the brain tumor, not for the cerebral hemorrhage. Usually with a child with a cerebral malformation, there'll be a history of a neurodevelopmental problem. They won't be a normal child otherwise. And with tetanus, you know the story, a history of a penetrating injury, and usually in an unimmunized child. And similarly with children with metabolic disorders, usually there's a history of a neurodevelopmental problem, or they have these other features, acidosis or hypoglycemia, and you can sometimes measure the ammonia and that will be high. But I really want you to focus on making that distinction between CNS pathology, the child who doesn't recover in the expected way that a child who's had epilepsy and had a seizure, or a child who's had a febrile convulsion, that those children recover typically after their seizure, but those children who have serious CNS pathology don't recover, and they either have persistent poor conscious state, or they have persistent neurological abnormalities like a hemiparesis or a cranial nerve palsy, or they remain having seizures. Often their seizures are more focal, and it's our job really to repeatedly assess patients to see whether they're recovering at the expected level. And also, because if you repeatedly examine patients, then you'll be able to identify these sorts of harder neurological signs. They may have some upper motor neuron signs, or an obvious hemiparesis, or often these are subtle and they require you to go back and many times to examine the patient often. The treatment of refractory seizures. So let's get on to treatment now. The treatment is firstly airway, breathing, and circulation support to prevent secondary brain injury. We talked about that. And then to give short-acting anti-epileptic drugs to stop the seizures. So you want to stop the seizures, and then you want to give a longer-acting anti-epileptic drug to prevent further seizures. And I'm going to talk a bit in the next few minutes about the sorts of medications that you can use for both of those purposes, and some of the pitfalls of using these certain drugs. And then you need to make a diagnosis and provide obviously specific treatment for that condition. There is in children with status epilepticus, as we've talked about with other conditions, there is a golden hour, and you really should be trying to do all of this within the first hour. Airway, breathing, and circulation support, preventing further seizures, stopping the seizures that currently exist, and making a diagnosis and getting the patient onto specific treatment. That should be able to be done within the first hour. You won't always be able to make a diagnosis within the first hour, but giving empirical treatment for whatever the likely underlying diagnoses are. The Hospital Care for Children book, in terms of the drug management of refractory seizures, suggests that you should give rectal diazepam or diazepam slowly by intravenous injection as the short-acting anticonvulsant to stop the seizures. And then if there's further convulsions, then giving phenobarbital. It's the same as phenobarbital. And that's essentially what the most standard treatment books around the world say, including the P&G standard treatment book. It suggests diazepam first, followed by another dose of diazepam if the child is still seizing, and followed by a longer acting um, uh, anticonvulsant that will prevent further seizures if you can get control of the seizures, or even if you can't. If there are repeated convulsions, then load with phenobarbital. And usually the time differences between those is about 10 minutes. Some of the newer guidelines suggest 5 minutes, so you give a dose of midazolam or diazepam and wait 5 minutes. If the seizure hasn't stopped, give another dose. And some guidelines say 10 minutes. What matters is that it's a fairly short period of time between those first two doses of short-acting benzodiazepines, whether it's diazepam or midazolam. The P&G standard treatment book is similar, says using praldehyde, which is similar to diazepam to start with. It's similar but different. I'll talk about praldehyde, but the same type of thing. Give one dose of the short-acting drug, whether it's praldehyde or diazepam, followed by, if the child's still seizing, then give a longer acting agent such as phenobarbital. And the time difference is typically 10 minutes between the three. So if a child's been seizing for 30 minutes, then they should be receiving their loading dose of phenobarbital by that stage after having their airway, breathing, and circulation supported. Now, praldehyde is commonly used, and it's quite an effective anticonvulsant, but it has some complications. It's actually a very painful intramuscular injection, and it can be given intravenously, but it's a bit more, as you know, a bit more complicated to give intravenously. But when it's given intramuscularly, it can be very painful. It certainly causes CNS depression, but all the anticonvulsants do that, whether it's diazepam or midazolam or phenobarbital, they all cause CNS depression. If it's given intravenously, it can cause hypotension, but again, they all can do that. It is very commonly associated with tissue inflammation, praldehyde, when it's given intramuscularly, and it's not uncommon to see local abscesses forming because of praldehyde intramuscular injection. There are some drug interactions and some toxicity, hepatotoxicity. It's not very common, but it can occur, and the elimination of praldehyde is through the lungs. And so in a child who's got pneumonia, they may not clear the praldehyde as well as other children would do so, for example. So if you've got a child who's got meningitis and pneumonia, they may not clear it quite as well. And so the drug levels may build up a little bit more. It's also an irritant, skin irritant. So you want to, in terms of the staff and patients, it's really important that you don't get it on your hands. But it is an effective anticonvulsant. I would say that it's an effective anticonvulsant. Remember, if you are giving intramuscular praldehyde, it's very important to give it in the upper outer quadrant because it can cause a serious neuropraxis and nerve toxicity if it's given into the gluteal nerve in the buttock. So that's praldehyde. I wanted to touch on diazepam and phenobarbital because in the WHO and our standard treatment book recommends using diazepam and phenobarbital, and both of those drugs are good drugs. They're also quite effective drugs. The problem is when you use them multiple doses of diazepam. So it's not uncommon you see a child who's been in the ward for a while and they might have had several seizures overnight and they've had several doses of praldehyde or several doses of diazepam. And it's the combination of multiple doses of diazepam combined with phenobarbital that becomes dangerous. And so any child who's needed more than 2 doses of a short-acting agent, well, one should be on a longer acting agent, and two, they should be monitored in a HDU or an ICU because they're much more likely to have respiratory depression. And this is a study that was done in children with cerebral malaria, a very important study, and it found that those patients that had required more than 3 doses of diazepam, 3 or more doses, combined with phenobarbital, did much worse. They had a much increased risk of dying. And I think that the cause of death was mostly central nervous system depression, respiratory depression, hypoxemia, airway obstruction, those sorts of things, hypotension, all the potential for secondary brain injury. So that's why children who need 2 doses of short-acting need a long-acting, and they need to be managed in an ICU setting. The APLS guidelines, these are the Advanced Pediatric Life Support Guidelines, is very similar to the WHO and the PNG Standard Treatment Guidelines. This, you won't be able to read this, but the only difference is that midazolam is a preferred drug to diazepam. It doesn't I don't think it really matters that much, but the differences are 5 minutes. 5 minutes between the doses. So if a child's not stopped seizing after 5 minutes of midazolam, then another dose is given. If the child's still not stopped fitting, then a long-acting agent is given. And if the child's not stopped fitting after that long-acting agent is given, whether it's whatever the long-acting agent is, I'll talk about those shortly, then the child requires airway support and intubation. That's the algorithm for the Advanced Pediatric Life Support, very similar to what WHO are recommending. So in terms of just a summary of the anti-epileptic drug use in status epilepticus, first of all, a maximum of 2 doses of short-acting anticonvulsants, 10 minutes apart, 5 to 10 minutes apart. And the options are diazepam given rectally or intravenously. You never give diazepam intramuscularly. It's very painful, and never do that. Very irritant as well. Or paraldehyde, diazepam or paraldehyde by deep intramuscular injection, or it can be given rectally, or it can be given intravenously. Or most of the APLS guidelines suggest midazolam if you have it available, and it's a good anticonvulsant drug, partly because it's water soluble, and it means it can be given transmucosally. So you can give it intranasally, squirt it up the nose, or you can give it under the tongue, or you can give it intravenously or intramuscularly. The doses are written there. After 2 doses of a short-acting anticonvulsant, then if a child's still seizing after a further 10 minutes, then they need a long-acting agent. And as we've talked about, the long-acting agents, there are a variety of options, and one is phenobarbital. We've talked about how that's been standard for a very long time. It's a very good drug, but it has some side effects. But phenobarbital is a standard. Phenytoin is also often used in many countries. It has some side effects as well, like phenobarbital. And then there are 2 other anticonvulsants that I would say, have come into increased use in recent years, in the last 5 or 10 years. And one is a drug called levetiracetam. It's sometimes called Keppra. And the other one is called sodium valproate or valproic acid. And both of those drugs are now available as intravenous preparations, and both of them are on the WHO Essential Medicines list for children, in recognition that some of the older drugs, some of the older anti-epileptic drugs have a number of side effects that make them less desirable. However, the choice can be limited, and it's not that phenobarbital and diazepam aren't effective. They are, but they require a higher level of monitoring and a higher level of concern about secondary brain injury from all those causes: hypotension, hypoxemia, respiratory depression, CNS depression, etc. Levetiracetam was put on the WHO Essential Medicines list for children in 2023 after quite a number of studies showed that it was highly effective, equally effective in the management of status epilepticus, and associated with much fewer side effects than some of the traditionally used medications. And so levetiracetam, or the other name for it, as I said, is Keppra. That's the trade name. It's a very safe drug. It can be children can have a load of levetiracetam relatively quickly. I usually give it over about 10 minutes in a child who's got refractory seizures, and then they get put on a maintenance of levetiracetam. It has minimal side effects compared with phenobarbital and diazepam. It causes much less respiratory depression. Compared with phenytoin, it causes fewer cardiac side effects. Phenytoin can lead to cardiac arrhythmias and hypotension, and levetiracetam really does that. So it's a safe drug that's equally effective but safe. I won't go through this, but in all the studies that were done in many large studies of levetiracetam and other drugs, it showed that both the effectiveness was the same and the side effects were less. These are a plot of the adverse effects, and you can see if I won't talk about meta-analyses now, but you can see that this favors, for example, levetiracetam over phenytoin in terms of side effects, must associated with fewer side effects than phenytoin. Sodium valproate's another anti-epileptic drug that's been on the WHO essential medicines list for about 10 years now. It's of course, it's been on the essential medicines list, the oral form, for some time, but it's a longer acting agent that can prevent further seizures in status epilepticus, and it has a similar efficacy to levetiracetam, to Keppra. It's not a drug you load with usually. Sometimes a loading dose is given. I don't use it nearly as much as what I use levetiracetam. Many children are on sodium valproate anyway, and you're not quite sure what the levels are. It's not as safe in small children. There's a rare risk of hepatotoxicity, but it does have a better side effect profile than phenytoin, for example, where it results in sodium valproate is less likely to cause cardiac arrhythmias or hypotension. So it's also quite a safe drug to be used, but I think levetiracetam is probably a preferred drug in pediatrics. Now, I hope from what I've said, you know that you can see that all anticonvulsant drugs, whatever they are, can cause CNS depression. That's actually how they work, isn't it? Seizures are a hyperactivity of the electrical activity of the brain. So the drug themselves, if they're going to suppress seizures, will also reduce CNS electrical activity. So therefore, they will get some CNS depression. But some of the drugs cause less respiratory depression than others, levetiracetam being one. Some have safer side effect profiles than others, especially on the heart and the liver. But regardless, the more drugs that a child receives and the more combinations, the greater risk of CNS and respiratory depression or hypotension or secondary brain injury from those things. So we have to be very careful. As I said, if a child needs more than 2 doses of a short-acting agent, they should get a long-acting agent, and they should be managed in a high dependency area of the ward or an ICU. I've said that before. So you treat their airway, where you should treat their airway, breathing, and circulation, and treat the underlying condition. Try to make a distinction between a relatively benign type of illness and a child who's got serious CNS pathology, be it any of those list of things we talked about, whether it's, and treat empirically to begin with. Empirical means you treat to start with and then try to work it out afterwards. Because if you delay treatment until, for example, you were doing a lumbar puncture to diagnose meningitis, then you may have missed the opportunity to treat a child properly. And remember, I talked before about the golden hour. I think that's very important in children with status epilepticus or prolonged seizures. You want to try to get all the definitive treatment initiated within that first hour and have the child stabilized. And then after that, you can work out a bit more exactly what the cause is. Most children who've got prolonged seizures, who are on a full prolonged, a longer acting agent, who need to be managed in a HDU or an ICU, need some sort of brain imaging. Now, that's not going to be available in all locations, but where it is, then doing a CT scan can be very helpful, because you can identify if a child's clinically not waking up, then you need to find out why. And it may be because they've got a hemorrhage, which you can detect on a non-contrast CT scan, or you may need to give contrast to detect other things like a brain tumor or meningeal enhancement from CNS TB or meningitis a uh, or a stroke, for example. So usually a contrast enhanced CT is what's being done to try to differentiate the cause in a child who's not following the normal trajectory. Most children, the vast majority of children who have febrile convulsions do not need a CT scan, but if the child's not recovering to the expected level, then it's ideal to do so. I've talked about this before to try to make a differentiation of the causes clinically before you consider any more complex imaging. I think you can get pretty close to a diagnosis based on history and examination, and the neuroimaging is only is valuable if you're still uncertain and if you have access to it. Sometimes we get used to, a standard history and examination, but I'd encourage you to go a little bit further than the standard. This is do fundoscopy in patients who've got refractory seizures if you can, and because you can often see things. This is a child who had cerebral malaria, and there are characteristic features of this fundoscopy that tell you that the child's got cerebral malaria. Retinal pathology is very common. Malaria retinopathy is very common in children who've got cerebral malaria. Of course, many children have malaria parasitemia. They don't have cerebral malaria, but they'll have a high fever and they'll have a febrile convulsion related to their malaria. It doesn't mean they've got cerebral malaria. But if you see these changes, you typically see a sort of whiter areas on the fundus. They're sort of ischemic or microvascular ischemic areas, or you can see here it's very clear that the child's got widespread retinal hemorrhages, also seen in cerebral malaria. So sometimes beyond a standard history and examination, you can look for other things like fundoscopy and look for other features of malaria or TB, etc. All children with status epilepticus need neuro neurocritical care. They need to be managed in a place where they can be monitored well and have good supportive care. So monitoring of their airway, their breathing, their circulation in a standard way with pulse oximetry, monitoring their respiratory rate and their heart rate and their pulse volume, all the things we've talked about before, their conscious state, documenting the seizure frequency and their blood sugar. And there are a number of things we can do, even if we don't have we don't have full intensive care. They can be nursed 30 degrees head up because that reduces any cerebral edema. It also protects their lungs from aspiration. They can have airway support, so suctioning to reduce the risk of aspiration, and some sort of respiratory support with oxygen as a minimum. And then some children need supportive ventilation. You can do basic things like measuring their serum sodium to make sure they don't have hyponatremia, and because that's common and that can lead to cerebral edema. And then if they've got signs of cerebral edema, then considering mannitol. I often put children on about a quarter to a half a gram per kilogram of mannitol twice a day for 48 hours if I'm worried about their possibility of having cerebral edema. It's all part of supportive care. Remember, use a color-coded monitoring and response chart so you can see whether the child's making the expected recovery or not, and repeatedly examine them. I think that's really fundamental. Repeatedly examine them. If a child's got ongoing seizures, then it's really important that you look at other organ systems for the effects of those seizures. We've talked about the airway and the breathing ones, but remember, circulation can be impaired in children with status epilepticus because of the drugs that they receive. Sometimes if children have got a temperature above 38 and they've got status epilepticus, that's very likely to cause ongoing seizures, and it will mean that the drugs that you're using won't nearly be as effective. And so I always try to control the temperature in children who've got who've got hyperpyrexia, so that they're more like you're more likely to be effective with your anticonvulsant medications. You won't be able to control refractory status epilepticus if a child's got a temperature of 39, for example. You need to bring their temperature down into normothermia. As I said, look at their electrolyte, look for electrolyte imbalance, because both hyponatremia and hypernatremia are relatively common in children with status epilepticus, as is hypoglycemia. They're quite common abnormalities, and you should look for those and try to manage it. Occasionally, you'll see children with status myoclonus or status epilepticus who have rhabdomyolysis. They've had seizures for so long. If seizures go for more than an hour, then a child is likely to have some degree of rhabdomyolysis because of the constant muscle contraction. It's a bit like running a marathon. The muscles get worked over time because of the status myoclonus. And that can sometimes lead to acute kidney injury. So you need to be sure that the child's kidneys are functioning well. Sometimes they'll get cerebral edema, and sometimes there'll be systemic inflammation from the underlying cause or a hospital-acquired infection. So just need to pay attention to the other organ systems of any child who's got status epilepticus. It's not just about the brain, but all of these things can result in secondary brain injury ultimately. I want to say something about outcomes of status epilepticus in children, and it is very dependent on, it's not surprising, it's very dependent on the severity when the child presents, on their underlying condition. Obviously, if they have serious CNS pathology, it depends on the quality of treatment they receive. It is very dependent on their quality of treatment in the first hour and the prevention of secondary brain injury. And in the studies that have looked at it, the pre-hospital treatment, like the care-seeking behaviour by parents, or if a child's being brought by healthcare providers, by an ambulance, or being referred from another hospital or a health centre, then the type of complications that arise during transport become very important, because that's the time when a child is most likely to suffer secondary brain injury if they're not managed properly in the transport phase, or when they first get to hospital in the emergency department. That's why the golden hour is very important. It depends on whether they've got, I would say, refractory seizures if they continue, or if they're aborted by the first, for example, the long-acting agent you give, whether it's phenobarbital or levetiracetam. If that aborts the seizure and they don't have any more, then yes, they've had status epilepticus, but they have aborted status epilepticus, and they have a much better outcome than children who have ongoing seizures despite the long-acting agents, or despite two doses of the short-acting agents. The mortality from status epilepticus is very broad, between 3 and 20%, and the morbidity is about 15%. So at least I've talked about the morbidity from other organ systems that might get damaged by recurrent seizures. And so it's a condition, one, that's very common, two, that we see, I think, at least most hospitals will see 1 or 2 cases a week of children who have refractory seizures. So we really do need to be good at understanding this. For children who recover from status epilepticus, if they go on to develop epilepsy, then they're likely to have recurrent status epilepticus, or recurrent or sometimes a worsening of their previous epilepsy. But I think the key thing is that the quality of treatment in the first hour is really crucial to the outcomes for these children. And so I hope that's a quick run through about status epilepticus and how we manage it, and how we might distinguish between conditions that are relatively benign and those that are more serious. So I'll send the slides around, but I would encourage you to look at that, especially that table of differential diagnosis, and try to really understand the different causes and the clinical features that suggest one diagnosis over another, so that we can be better at distinguishing between benign and more concerning problems. All right, that's all I want to say today. I'm going to stop sharing my screen, and I'm happy to answer any questions that anyone might have, but I'll just stop the recording now. But thanks everyone for attending and listening today. I'm happy to answer any questions you might have.